Hello, Jackie P listeners. My name's Ed Gerstenfeld, one of the associate editors for Jackie P, and it's my pleasure for this podcast to be discussing the senior author of the study Pulmonary Vein Isolation with Contact Force Sensing Large Tip Focal PFA Catheter with 3D Mapping for Paroxysmal AF, the Omni IRA 3-month study results. And this is going to be presented at the upcoming Heart Rhythm Society meeting as a late-breaking clinical trial with a simultaneous publication in Jackie P. And the primary author is Matthias Duschhaver, and he's from Bruges, Belgium. So welcome, Matthias.
Hello. Hello, Ed.
So good to have you and to get some insights from the study. So, I took this from your paper. It just shows the OmniPulse catheter, and then there's some unique features where you can use this index to measure endpoints in terms of each ablation lesion. But maybe you could just tell us a bit about the catheter and the waveform and how you used it in the trial.
This is a single tip catheter, but it consists of a smooth atraumatic compressible tip. You see that 6 splines form a mini basket with a diameter of 12 millimeter. Each of the splines contains 2 stacked electrodes. The relatively small electrode, 0.5 millimeter, with an interelectrode distance of 2.25 millimeter. In the shaft of the catheter, which is a bidirectional catheter, 7.5 French, there is an integrated reference electrode for improved signal quality, but there is also a contact force sensor spring, and there is also a magnetic location sensor, which allows mapping. It's connected to a pulsed field generator, so it's PFA only. And it delivers bipolar biphasic pulses in a range of 1200 volts. And it does so in a series of grouped pulses. From preclinical data, we know that the actual lesion depth is dependent on the measured contact force and the number of series that were applied. So basically, the index, which is related to contact force and the number of pulses, gives you a good estimate of lesion depth in the preclinical model. It's called the PF index, and it's used in patients to actually titrate your delivery. And the sweet spot is around 8 to 12 series of pulses to reach the desired PF index. And on the posterior wall, we targeted an index of 400, which was shown to be transmural in the preclinical model. And on the anterior wall, we had a target of 550 index value. Now, to reach a certain index, you can either use the number of pulses, or you just have to pay careful attention to the contact force at the beginning of your application. So basically, we were able to reach the desired target in our patients, both for the posterior wall and the anterior wall. From the preclinical data, we also knew that the intertag distance should be maximum 9 millimeter. And after performing a number of cases in patients, we observed that 6 millimeter was even better at the anterior wall to reach transmurality and contiguity. So the protocol in the last 108 patients was an index of 400 posterior wall, 550 anterior wall. Be sure that you had enough contact force at the start of the procedure and respect the intertag distance.
Fantastic. And so you gave repeated applications to reach these indexes, or does it automatically give the number of lesions needed to get there?
It's automatic. So if you start an application, it will start a series of pulses, and after 8 to 9 to 10, you decide to stop if the index is reached, and you will get one purple tag. And the purple tag is dark purple or light purple according to the index.
Fantastic. And just from my comfort level, like, is it because it's a blunt catheter, or is the contact force, like if I saw a contact force with a standard catheter more than 35 grams, I would start yelling at the fellow. But
Yeah.
saying greater than 35, is that because it's a flat catheter or because the force is
Yeah. So basically the splines, they distribute the force, and then you go to the second law of Newton that says that pressure is force divided by the area. And if you then continue to do math, then you get a ratio of around 4 to 1, 5 to 1. So we were not surprised to hear that in bench testing, the perforation contact force is 400 grams with this catheter. So it is a mind switch. So you can reassure your fellow that it's okay. He will never reach the more than 100, by the way.
That's good, good to know. Good to know. And then I saw in your paper that it's the saline infusion is either 4 or 40 during ablation, which is more than we use with some of our catheters. Was that an issue at all in terms of the amount of saline you gave?
Good question. So we reached around 1,000 ml, slightly more per procedure. And we can do the math again, but it's because of the 40 ml per minute during the applications. Why is there irrigation? First of all, because it can. That's how it was delivered, and that's how the engineers developed it. Can we think of reasons as clinicians? Maybe it may prevent thermal injury. Post-field ablation is probably not completely devoid of thermal effects. Number three, it might be that the irrigation might be helpful again to prevent phenomena like hemolysis, but actually that's work to be done.
Yeah, no, that was interesting because some of the PFA catheters, obviously, one of the benefits potentially is um, not needing irrigation, but I think
Absolutely.
still to
Absolutely.
work out.
One liter at the end of the day is in patients with heart failure. It's not really what you would
Yeah,
prefer.
I agree. So this is your central illustration. Can you maybe just summarize the
Yeah.
workflow and enrollment in the study and what you found?
So in this paper, which is a sub-study of the large Omni-IO study, we presented 3 months results. We wanted to show the acute effectiveness, the safety, and the PVI durability using the investigational catheter. 136 patients were treated per protocol. Overall, it was performed in 13 centers in Europe and Canada with 21 operators. We discussed the ablation procedure. The acute effectiveness endpoint was adenosine or isoproterenol proof isolation. At the end of the procedure, we reached 100% pulmonary vein isolation. And of note, it was 97.1% that we observed the isolation being initially proved to the adenosine. The safety endpoints were overall in the 136 patients were evaluated. It was primary adverse events up to 7 days, for tamponade up to 1 month, for PV stenosis, fistulization, and then death up to 3 months. And we observed 3% primary adverse events. 3 vascular access complications, which were procedure related but not catheter related, and 1 pericarditis. So an overall good safety profile. Also important to notice what we did not observe: no PV stenosis, no esophageal injury. That's important. From a safety performance or safety perspective, there was an important sub-study in 31 patients. They underwent neurological assessments. So these were pre-specified patients, neurological assessment, including brain MRI, pre-procedure, at discharge and 1 month, esophageal endoscopy within 72 hours after the procedure, and cardiac CT or magnetic resonance angio of the pulmonary veins pre-procedure and at 3 months. And we observed in these subset patients, 31 patients, we observed one asymptomatic silent cerebral lesion that resolved after 1 month. We observed no esophageal injury, and we observed no PV narrowing defined as more than 50% diameter reduction in the patient population. Interestingly, those same 31 patients also underwent a PVI durability assessment at a mean of 75 days. And in these patients, we observed that 85% of the veins were durably isolated. So this was, again, to stress, this is a pre-specified patient population without any symptoms. So these were the main results of the study. Acute effectiveness 100%, primary adverse event 3%, and durability at vein level of 85%.
Yeah, fantastic. I thought the remapping data was really, important as we're exploring all these new technologies. Just curious in your take, obviously you found 85% PV durability, 62% of the patients with all 4 veins isolated. As EPs, I think we all hoped PFA would, how can we know what the effect of PVI is? We thought PFA would get us up to maybe 90s or, more effective PV isolation chronically. I mean, this is in realm with, I know, with other catheters are showing, but do you think that's the sort of limit that we can achieve, or are there things we can do to improve this?
But there's certainly things that we can improve. But if we look at the overall results, the 85% durability rate, I added in the paper a graph where I carefully dissected the durability on a vein level. And indeed, it seems comparable to what we've done with thermal ablation, but also if you critically reevaluate what pentaspline catheters did, or a Sphere 9 or a Sphere 360, it's around 85%, 90%. Now, if you look at this catheter, I worked with this catheter, you see that it's again happening at the carina, more so maybe at the right posterior carina. Maybe each catheter has its own weak spot, but it's the carina. And
Yeah,
at the
I was a little
carina,
surprised this is your reconnection chart. There was even
Mhm.
a higher number of reconnections posteriorly, whereas usually
Yeah.
we expect it at the
Yeah.
carina. You think that's going to be better when you adjust the ablation index with your?
Yeah, absolutely. And it's for instance, with the SmartTouch dual energy catheter, it was also the carina, but it was more the left carina.
No.
On the other hand, these are small numbers, so we shouldn't probably overinterpret these results. What I think is still wrong, in this catheter at least, this is the first set of studies in patients, and the tag that you did see, as you know, or in this study, it's important to know, it was placed at the very beginning of the application. So after 1 second, you could do whatever you want, or your fellow, it was not the fellow, but I mean, you could move for 4 or 5 centimeters. Nobody will notice that this purple tag was not at that point. So there is no respiratory gating. There is no respiratory plus gating. It means that this tag is probably, if you're a good operator, it will probably be there. So it's a limitation, and they will certainly improve. On the other hand, we also know that in humans, in contrast to animals, maybe there is a more noisy relation between the index and the actual lesion depth because it's also very depending on coupling and maybe in trabeculated tissue like the carina. The index correlation to actual lesion depths may be more noisy. So we will improve. Also, stability, of course, of the sheet, of the operator is always a limiting factor.
Yeah. And any concern or that these might be less antral perhaps than some other approaches, or you think they're equivalent?
Oh, the operators, let's say, so we have 21 operators, they were free to ablate at any level they felt comfortable with. I wouldn't be surprised if this was my procedure. I've been ablating at the LAPV junction also with radio frequency, always. But I'm sure there will be operators with wider lesions. And the versatility of this catheter allows, of course, to do the necessary investigation in this field. We can go with wider antral lesions.
Fair
But we
enough.
shouldn't be naive. The more we go wide, the more we will encounter thick tissue, and we will have non-first pass isolation, adenosine-proof isolation, adenosine reconnection. So
That's fair.
maybe LAPV junction is a good position to start the catheter.
That's fair. And then last question is obviously putting your investigator hat aside and as an EP, lots of technologies that are out there, but the bold ones that are FDA approved in the US and Omni is in there. Any thoughts overall, assuming this catheter goes through to approval, when you would pull this catheter versus the others? If you have a first-time de novo paroxysmal AF patient, is this Omnipulse the catheter you'd pull, or would you reserve it for another type of patient, or you think they're all equivalent?
No, no. I know how this catheter might evolve. We will probably go to Omnipulse fast, meaning that applications won't last for 12 seconds, but in the range of 1 to 2 seconds. That will, of course, be huge advantage, but we're not there yet, and we're testing it preclinically. That being said, will it be a competitor for the devices that we now use for de novo paroxysmal? I don't think so. The catheters more to the left, far away, maybe more in particular. Also the Volt, I find very appropriate for simple PVIs, no learning curve, skill normalizer, etc., with good durability data, with eyes, with good contact assessment. Where do I see a catheter like Omni? I would love to use it in patients where I do my roof line if I need it, my mitral line, if it's going deep enough. We'll see with new recipes whether we can increase the depth. I want to treat my atrial tachycardia. Maybe I want to use it for dispersion-guided ablation, more patient-specific. So not actually what we now tested in the PVI only study, but okay, as a start, we needed to go to PVI only. But I would reserve it more for the non-PVI patients.
Redo procedures, maybe. Yeah, no, I agree. Fantastic. So thanks so much, Matthias, for your insights into this important study. And we look forward to seeing your presentation at HRS in San Diego and to seeing the fully published manuscript. Thanks so much.
Super. Thank you.